Good morning, everyone. I'm Jigar Raithatha. I'm the CEO of Constellation Pharmaceuticals. Thanks for joining us here today for our presentation. We will be making forward-looking statements, so please refer to the disclaimers. So Constellation has two wholly owned clinical programs, CPI-0610, focusing on the BET family of proteins, and CPI-1205, focusing on EZH2. CPI-0610 is currently being developed in myelofibrosis, and the early data that we have in hand point to the potential for disease-modifying effects. CPI-1205 is being developed in combination with androgen receptor signaling inhibitors, abiraterone or enzalutamide, and we've seen initial clinical activity in our phase 1b studies and have now initiated the phase 2 studies to test those combinations. We anticipate having data updates for both of these programs in the second quarter of this year, and additional updates in the second half of the year as well. Next up at bat in our pipeline is CPI-0209. This expands our EZH2 franchise with a next-generation potential best-in-class EZH2 inhibitor, and we'll use that going forward for additional applications for EZH2 inhibition. And all this has been made possible with a robust focus and effort that all emerged internally from a platform that we built from the ground up. So in terms of the near-term catalysts, CPI-0610 is currently in a phase 2 study in myelofibrosis. We anticipate in the second quarter presenting data from approximately 18 to 20 patients with at least 3 months of follow-up. In addition, CPI-1205 has completed enrollment in a phase 1b study in combination either with abiraterone or enzalutamide, and we'll be presenting that phase 1b data at AACR. We've already initiated the phase 2 portion of this study, and we'll aim to provide interim update on that study later on in the year. And then CPI-0209, our second-generation EZH2 inhibitor, will be in the clinic sometime around mid-year. Our vision for 2019 is that it's a year of data, and that with that data in hand, we'll be able to transition ourselves into a late-stage oncology company. And that will be driven through generating positive proof of concept with 610 and 1205 and moving into pivotal studies, expanding our EZH2 franchise with 0209 and moving that into the clinic, and then delivering novel candidates that will emerge from our pipeline candidates as well. So late-stage oncology company with a pipeline behind that. So focusing first on CPI-0610. To give you a bit of a background, 610 is a potent and selective inhibitor of BET proteins. Prior to initiating our MS study, we did treat 138 patients in various phase 1 studies across various heme malignancies. And with that, we've been able to demonstrate a very clear understanding of the PK, PD, and safety profile of CPI-0610. In addition, we've been able to demonstrate preliminary clinical activity, potential disease-modifying effects in myelofibrosis, as well as activity in a subset of lymphoma, ABC, DLBCL. Also, we've been able to demonstrate a differentiated safety profile compared to other BET inhibitors. Specifically, the on-target toxicity of BET inhibition is known to be thrombocytopenia. The thrombocytopenia that we see with CPI-0610 has been reversible and non-cumulative and quite manageable. And as you can see from the chart on the right-hand side of the slide, we have quite a wide therapeutic window. We saw activity all the way down to 40 milligrams in our lymphoma study. The activity that we see, routine target engagement and efficacy, and the dose that we're using in MF is 125 milligrams, and this is almost half of the maximum tolerated dose of 225 milligrams. The profile that we generally see emerge from other BET inhibitors is a maximum tolerated dose and a minimal efficacious dose that are right on top of each other, and as a result, most BET inhibitors have not been able to traverse a significant therapeutic window and have run into toxicity that's either irreversible or non-cumulative. So the mechanism of action for BET inhibition and 610 in myelofibrosis is as follows. We anticipate that BET signaling impacts the transcription of NF-kappa B-mediated genes, which then impacts the expression of genes that secrete pro-inflammatory cytokines. We also know that BET signaling has a second effect, which is to arrest precursor myeloid cells before they differentiate into megakaryocytes. Now, megakaryocytes are the key cells that are proliferating in the bone marrow, and they're crowding out the healthy cells. They're also responsible for secreting inflammatory cytokines. And so by adding CPI-0610, we believe we can impact the bone marrow itself and give it a chance to heal. Now, the background around myelofibrosis, some of you may be familiar with this disease because the only approved drug today is a drug called Jakafi, which has done quite well in helping some of these patients. It affects about 17 to 20,000 in patients in the U.S. and roughly on the order of the same magnitude in Europe as well. Now, ruxolitinib was approved based on its ability to impact inflammation, and the results of that is to reduce the size of the spleen and to improve the symptoms in these patients. These patients are feeling the effects of inflammation systemically, night sweats, fatigue, and various other aspects that would cause a patient not to feel great. However, the on-target toxicities of ruxolitinib is also limiting. They also have to dose down quite a bit sometimes to manage these toxicities. Specifically, anemia tends to be one of the on-target toxicities of receiving ruxolitinib, and as a result, patients become more and more transfusion dependent over time. Ruxolitinib has also shown limited effects of improving the underlying disease itself. The bone marrow fibrosis has not been shown to be dramatically affected by treatment with ruxolitinib over time. And so our belief is that there's a significant unmet need that still exists in myelofibrosis patients. Specifically, there are no second-line therapies approved. There's an increased reliance on transfusion dependence as patients become more and more anemic, and the majority of first-line patients actually do not respond to ruxolitinib. And what we've been able to show with CPI-0610 is that we have an impact across all four hallmarks of myelofibrosis. And so we begin to be able to stake out the potential for disease-modifying effects. Now, as we think about what are the ways that we can develop CPI-0610 in myelofibrosis to address these unmet needs, first, we start with patients that are transfusion dependent at baseline in second-line disease. As you can see, as patients are treatment naive, roughly a quarter of these patients are transfusion dependent to begin with. But after 6 months of treatment with a JAK inhibitor, those rates increase over time. And our goal in these patients would be to convert them to become transfusion independent. For the patients that are not transfusion dependent, we would also look to improve the spleen response rates, or actually decrease the spleen volume, as well as improve symptoms and other disease-modifying parameters. As you can see here, that one of the best studies that was done in this context is with a drug called momelotinib, another JAK inhibitor, that was unable to show more than a 7% spleen response rate in these patients. And so our view is that having a drug that can have consistent reduction in spleen volume, perhaps combined with other parameters of disease modification, would be quite compelling. And then lastly, we'll look to focus on first-line patients as well as a longer-term strategy, where we'll look to increase the percentage of patients that achieve a spleen response over and above the 30% of patients that achieve a response with ruxolitinib. The goal here is to drive more of these patients over the line by adding a subsequent mechanism or an orthogonal mechanism that can drive to a response, but also a mechanism that might allow us to keep patients on a more relevant level of ruxolitinib, a higher dose of ruxolitinib, and to drive more patients over the line. To do this, we've now started a phase 2 study where we're enrolling patients in multiple different cohorts. We have 2 different arms of second-line disease. One is if patients have come off of ruxolitinib after not responding and are looking for other treatments. In that case, we'll provide them with CPI-0610 as a monotherapy. In some cases, even though patients are progressing or the disease is worsening, they still will stay on ruxolitinib because there's nothing else or there's fear of a cytokine storm that could emerge. In this case, we will add on CPI-0610 on whatever stable dose of ruxolitinib they can tolerate. In either case, the patients are progressing and the disease is worsening. Across both of these arms, we're stratifying also for transfusion dependent status. So we're prospectively enrolling patients that are either transfusion dependent or not dependent or non-transfusion dependent at baseline. And that'll give us the ability to have discussions with the FDA in a prospective way about various endpoints. And as I mentioned, we'll soon begin enrolling patients in a first-line cohort in combination with ruxolitinib. The endpoint that we're looking for in the transfusion-dependent patients is the conversion to become transfusion-independent. And in the non-transfusion-dependent patients, we're looking at spleen volume reduction, symptom score improvement, and also other parameters of disease modification, perhaps bone marrow fibrosis, erythroid response, or other parameters as well. So I'm going to share with you today data from the first 4 patients that we've treated in this study. And these are data that were originally disclosed in our S1 filing last year. Subsequently, we updated the results to a December 10th time point on these 4 patients. And what you can see here is that each of these 4 patients have maintained an ongoing responsiveness to therapy. So 2 patients were treated in combination, as depicted by the orange bars. Both of these patients, as of the December 10th cutoff, were ongoing with treatment for greater than 16 months. We've also treated 2 patients in the monotherapy arms, and those patients continue to remain on therapy with that response for greater than a year. All 4 patients have achieved some type of symptom improvement, and 2 patients have had severe hematologic abnormalities that we've been able to correct. I'll focus in on the patient number 2 here that was transfusion dependent at baseline to give you an idea about what happens in this context. So that's this patient on the next slide here. This patient was regularly being transfused with 2 units of blood every 4 weeks and was having a difficult time maintaining a hemoglobin level above 7 without a blood transfusion. But every time the patient received a blood transfusion, you can see the hemoglobin level spiked, came back down, spiked, came back down. But as we added on 610, we started to notice that the amount of blood being transfused was petering out. And then the patient became transfusion independent, and that's now persisted as of our December cutoff at 52 weeks and counting. Interestingly, we also see the hemoglobin levels increase despite not having blood transfusions, and also platelet levels also increase despite being on 2 therapies whose on-target toxicity is thrombocytopenia. So this was the first piece of evidence that we received that potentially what we're doing here is impacting the underlying disease and making heme function actually better. And then when we look across all 4 patients, we see this same trend of improving hemoglobin levels exist in all 4 patients. Lastly, to round out the story, we've been collecting bone marrow biopsies for each of the patients that we've enrolled. These are the biopsies from the first 2 patients where we've been able to analyze the baseline and subsequent bone marrow biopsies. These patients are both monotherapy. They've been treated with nothing else since they've been on our study except for CPI 0610. They're both patients that are heavily pretreated with mutations that predict for poor prognosis. And in each of these patients, we've seen a 1-grade improvement in the bone marrow fibrosis. This is a high bar. We're not expecting this necessarily to happen in every single patient, but we're quite enthusiastic to see these results in these 2 patients, and we'll continue to report on these data as we have them over time for the rest of the patients. So in terms of how we think about moving CPI 0610 forward in myelofibrosis as its first path to registration. As we mentioned before, there's continuing to be an unmet need in myelofibrosis where the existing therapies only impact a portion of the disease, and what we expect to be able to do with CPI 0610 is to modify the disease by impacting all 4 hallmarks of myelofibrosis. And so we'll be having discussions with the FDA later this year where we will be discussing various paths to registration. For the transfusion-dependent patients, our hope is that conversion of transfusion dependency to transfusion independent status would be quite a clinically meaningful endpoint in this subset of patients that is a substantial subset of that second-line patient population. For the non-transfusion dependent patients, we'll also look at spleen volume reduction, symptom improvement, and then bring forward additional support, perhaps anemia responses, improvement in fibrosis grade, or other biomarkers that can also supplement the spleen and symptom improvement that we see in these patients. Again, we're on track to have these discussions with the FDA at some point in 2019. Moving on to the EZH2 franchise, which is composed of CPI 1205, our first-generation molecule, and CPI 0209, our second-generation molecule. Now, the role for EZH2 in prostate cancer is actually well known. It was established initially by some of the work that was done by Arul Chennaiyan, who's an expert in both prostate cancer and EZH2. Arul was able to show that EZH2 levels or expression levels correlate with the stage of disease. But then he went a step further to demonstrate that the EZH2 function is important for prognosis in the disease. And so he looked at the genes that are methylated by EZH2 and suppressed and demonstrated that to be a signature for EZH2 activity. Then back correlated that signature to clinical data sets and demonstrated that EZH2 activity corresponds to outcomes in the disease. Our model for how this then works is thinking through the AR pathway. We know that the androgen receptor pathway is a key oncogenic driver of prostate cancer. Our belief is that EZH2 is synergistically enhancing that AR signaling to drive that prostate cancer. And we demonstrate this with a variety of preclinical experiments. What I show here are prostate cancer cells that we treat with AR inhibitors, in this case enzalutamide. We see similar effects with abiraterone. And the genes that are implicated here are the downstream AR target genes. And you can see some genes go up and some genes go down after they're treated with enzalutamide. When you combine enzalutamide with 1205, you essentially see the same gene signature. However, the magnitude of its intensity is hyperintensified. And so with that, we're then able to have a synergistic effect on the cell killing with these two agents combined. So then moving to the treatment paradigm in prostate cancer, once patients progress to metastatic castration-resistant prostate cancer, they're treated with one of two agents, either abiraterone or enzalutamide. In this context, most patients will have some kind of response, but unfortunately, all patients will progress. And once they progress, patients generally cross over to the AR therapy that they did not get first line. However, the activity in these patients is quite poor. And so our goal here is to add on CPI-1205 to enhance the activity, to take advantage of that synergy that we see in combination with an AR inhibitor and EZH2 inhibitor. And so to put a fine point on kind of what that activity looks like, we can thank Dr. Kim Chi from Vancouver, who recently did a prospective study and presented it at ASCO last year. What Dr. Chi was able to show in patients that were enrolled first line with either abiraterone or enzalutamide, and then crossed them over as they progressed onto the other agents did not receive. The ABI after ENZA cohorts demonstrated that 4% of patients achieved a PSA response, a PSA 50 response, but however, the time to progression was quite short. 1.6 months was the clinical time to progression in these patients. If you received abiraterone and then enzalutamide, the outlook was slightly better with a 30% PSA response rate. However, the time to progression clinically was also very short, only 2.7 months in these patients, pointing to the fact that something more is needed in these patient populations. Our goal is to add on CPI-1205 to see if we can achieve a deeper and more durable response in these patients. So early last year, we began testing the combination of enzalutamide plus 1205 and abiraterone progressors, and abiraterone plus 1205 and enzalutamide progressors. Now, the 1B was composed of a variety of different types of patients. The main goal here was to establish safety and a recommended phase 2 dose. And most of the patients here have been a mixture of either second, third, or fourth line patients, including patients that are post-chemo. In the phase 2 portion of the study, we've curated that patient population to be only second-line patients who have not experienced chemotherapy before. We've initiated this trial. The enzalutamide portion of it will be a randomized study, enzalutamide plus 1205 versus enzalutamide alone, to clearly demonstrate the impact of adding 1205 to the regimen. The abiraterone cohort will be a single-arm study, given the low response rates that you see with abiraterone on its own. We are also testing for a range of different biomarkers in these patients with the hope of finding biomarkers that we can use to enrich the patient population in a potential pivotal trial. So just to present to you kind of where we stand with the data that's been presented already, this was disclosed in our S1 filing again last year. At the time of that filing, we had 6 patients that were evaluable for PSA responses where we had a baseline and a second measurement of PSA. 2 of these 6 patients achieved an 80% reduction in their PSA. Both of those patients also had improvements in their metastatic disease. As you can see here, one patient had significant bone metastases that cleared after 3 months of treatment. We had a second patient that also achieved objective response by RECIST. We have now enrolled 36 patients across these cohorts in this study, and we'll be presenting those data at AACR. We've seen additional PSA 80s, improvement in metastatic disease, and also measuring circulating tumor cells, and we'll be able to present what we've seen on that parameter as well. As I mentioned, we've initiated the phase 2 portion of the trial, and we'll aim to present an interim update from that study in the second half of the year, which we think directly will speak to the population that would benefit most directly from the combination. Rounding out the franchise is CPI-0209. CPI-0209 is an EZH2 inhibitor that we designed a little bit differently from CPI-1205, and we think it gives it potential best-in-class qualities. One of the things that we learned about CPI-1205 is that there is a time-based dependency to its effect, and that with longer treatment, you tend to see efficacy deepen. And what we wanted to then do to see if we can shorten that onset to action by developing an EZH2 inhibitor that has almost irreversible qualities. So it binds EZH2 and then comes off in a very slow manner, outstripping the protein turnover. So now the activity is dependent on the protein half-life as opposed to the molecule half-life, and allows us to extract the full biology from EZH2 inhibition. This opens up a waterfront of broad application specifically to other solid tumors where we think the patient populations could be quite large. We've seen single agent and combination activity in these contexts, and we expect to start the phase 1 studies mid-year. To give you a sense of how this compares to first-generation molecules, we're presenting some data here from our workhorse models. This is a lymphoma xenograft model that has a mutation EZH2. Generally, we see regression with 1205 or other first-generation inhibitors at 10 times the dose that we would need to treat with CPI-0209. And the onset to action is initiated in a much more rapid manner and is quite durable. We've also tested very high hurdle models. In this case, this is a resistant prostate cancer model that very few agents have any activity with, and we've seen single-agent activity with CPI-0209. These aren't necessarily the indications that we would pursue with 0209, but we wanted to give you a sense of how that molecule behaves relative to other EZH2 inhibitors, and we'll disclose more about the clinical strategy over the course of this year. So in terms of value creation catalysts, 2018 was a year of execution for us, and 2019 is a year of data. We set ourselves up to proceed with several disclosures over the course of the year, starting with AACR, where we'll disclose the phase 1b data from CPI-1205 in the ProStar study. We think a very meaningful update for us is the CPI-610 interim update that we'll provide from the Manifest study, also in the second quarter of this year at a medical meeting. And then a very meaningful disclosure for 1205 later in the year as we have interim updates from the ProStar phase 2 portion of that study. And then, as I mentioned before, we'll have additional updates for the Manifest trial before the end of the year, and we'll add CPI-0209 into the clinic as well. Thank you very much. I think we also have time for a breakout session next door. Yep, I'm happy. We do have some time, so we can take questions now as well. Sorry, can you repeat the question? I couldn't hear what you said. Yeah, so if you're talking about mutational parameters for those patients? Oh, the spleen size. So I guess each of these patients everyone was second line. So these patients have progressed on Jakafi already. They actually had mutations that would predict for non-responsiveness to Jakafi, and we did see spleen volume reduction in both of those patients, as well as bone marrow fibrosis improvement in both of those patients. Any other questions? These were MRI measurements. Great. Well, thank you again very much for taking the time to attend our presentation. We're happy to follow up with any other questions next door in our breakout session.